start?
Right. Dr. Sanjeev Singh is the medical director, Amrita Hospitals, Delhi NCR, and is one of the key leaders in the NABH and Quality Council of India's work. He's an inspiring speaker and a great man who has worked with many institutions and now at Amrita Delhi. Previously, he was in Amrita Kochi and helped NABH in various aspects, teaching as well as in the accreditation journey. And he would be the right person. And this is one question that is in the mind of every stakeholder, whether it's hospitals or the worker or even the patients, whether accreditation is cost effective. So from the insurance perspective, they want the cost to be third rate. From the quality point of view, we want the top-notch quality. But in between, there is a aspect of cost. Indians are really price sensitive, and we always look at cost from many aspects, and that is one of the topmost priorities in our mind. Well, let's hear from Dr. Sanjeev Singh whether accreditation is cost effective or not. Over to you, Dr. Sanjeev.
Thank you, Chairperson Joy, Dr. Nirmal, and thanks, Dr. Agarwal and Dr. Lalu for organizing such a fantastic work. I'll be speaking on accreditation, and I'll carry it forward from what Dr. Atul Kochar was just mentioning. And I will try to sell NABH here, and I will send you the bill, sir. So I was doing a Lean Six Sigma implementation in Operation Theatre at our hospital here in Kochi. And we did work quite a bit in 6 to 8 months, and then we achieved a decent success. And I went up to our group medical director and said, "Sir, we have done well, we have worked hard, and we are at 3.4 Six Sigma level." So he looked at me and said that, "Sanjeev, there is a patient in 3301. He is a relative of CM. Make sure nothing gets goofed up this time." And I was very, very sad. There was a hard work which went through. And I also realized that there is, if I could use that word, attention deficit, because raw data and this may not make sense. So I learned my lesson. I went back. After 2 months, I came to meet him again and said that, "Sir, we are at 3.4. We have made a cost benefit to the hospital of 2.3 crores. Do you know what he said? He offered me a chair. He ordered a cappuccino with hazelnut, and he said, "What else I can do for you?" So cost, unfortunately, is a driving factor, and we'll see whether it makes sense in accreditation. Because right now, there is a cost which gets into calling the application fee, calling the assessors and assessment, and getting your infrastructure and all the training. There's a cost involved, and whether we could balance that budget is important. So that's the agenda which I'm going to cover. Importance is last point, which are case studies, and I'll narrate some of these case studies to make my point. So this is an article by Ashish Jha. He replaced Anthony Fauci at US government, and he was the chief of Harvard Public School. He did this work, and he wrote in this article, which is very recent in JAMA, that one case study found that the direct service survey fee were only 7% of the total cost associated with accreditation, and preparing was like a chore, but then the cost was not done. And then there appears to be a disconnect between what accreditation wants and what we are doing. Cost is never been calculated, and that's what he wrote in JAMA. Scandinavian countries have fantastic work. They have already done superb work. They have good accreditation standards. But this is a good article which was published at Safety in Health by Nicola, and which concluded that the detailed information about cost, select benefits associated with reaccreditation is there, but as opposed to the cost, benefits could be monetized. And that is where is the game, and that is where we need to. We cannot keep blaming the management. They are only concerned about dollar terms, but then that is, we need to learn to speak everybody's language. So As a good public health or as a good manager, we need to speak language which the clinicians needs to understand, good language which the nurse can understand and the paramedical staff can understand, and including the management understands. So what it takes to the accreditation to be cost effective, and we'll see how it could be done. But what was written is a small reduction in bed days gives you an opportunity to admit more patient, an opportunity to create that difference. And that is where it is important. Even JCI, so it's very high on cost because it goes into crores, getting these people for a document survey and survey to be done. But then it is 10 to 15% of the annual fee which goes into the financial audit, but the costs can only be offset if there are benefits. And if there is a benefit, and I think that is where we need to sort of start working. There is a triple aim project which is driven by Institute of Healthcare Improvement, which also says that we need to reduce cost. But importance here is that we generally use cost effectiveness as an obvious term. It's a khichdi term because we don't know what is cost benefit, cost effective, and cost utility, and that is why we don't calculate. So what does NABH says? Basically, it is talking about that we need to follow evidence-based practice. We need to have clinical care pathways. And based on that, the care delivery would be uniform and standardized, which should be delivered by a multidisciplinary team. Including nursing, they are saying that there should be a guidance note and clinical pathway even for the nursing. So these are some of the case studies which we would narrate regarding medication error, because they are asking about medication management. We saw there are huge statistics. We'll look at VT prophylaxis, healthcare-associated infections, and some of it. So if you look at medication management, unfortunately, it is always clubbed with adverse drug reactions and adverse drug event. And that is where medication error is never calculated and captured well. And there are plenty of them. It could be a near miss, it could be administration, transcription, prescription, dilution, dosing, many of this error. But unfortunately, when we were doing this data collection many years back, we realized that among the accredited hospital, also medication error was close to 0.001%. And that is where it is bad. So we did at various departments, and we looked at some of the gastrosurgical department. And if you introduce a group called clinical pharmacist or an individual called clinical pharmacist who is adequately trained, they drop in their cost and they balance the budget very soon. And they reduce the length of stays, they improve the efficacy of reporting, and both direct and indirect cost reduces. So if you look at cost of avoidance of medication error, just introducing a clinical pharmacist, the net cost benefit is close to 2 lakh of rupees. And cost benefit ratio, anything which is above 1 is good. And here, if you introduce a clinical pharmacist, it is close to 5. So how much is one medication error? We generally say we need to reduce it. But how much is one? And that is what we costed. It is close to 23,000 of rupees. And if you can save 2 medication error in a month, you are already fulfilling a salary of a clinical pharmacist. And that is what we need to drive. Because it's important, this medication management needs to be taken care, and that is what is expected from a good accredited hospital. Let's look at COP 16E, PSQ 6A, ROM 5, which talks about risk management and specifically talks about VTE prophylaxis. And this is again, unfortunately, my mother had a CA cervix, stage 1, got operated. She was supposed to, was in a most prestigious hospital in the country, was about to be discharged on the day 12, but then she had an acute cardiac arrest. At that point of time, it was diagnosed as pulmonary embolism. And almost 24 years back, there was absolutely no concept, even in a good prestigious hospital, of giving a good VT prophylaxis, and I lost my mother. And we don't still have a good risk management strategy of VT prophylaxis being given to these patients who post-surgery. So what does it cost? What does a pulmonary embolism cost to us, and what does a VT prophylaxis would cost to us? So if you have a pulmonary embolism, These are the tests which you need to do. So it would start from a basic CT, ECG, CT angio, 2D echo, and things like that. The total cost is about 44,000 of rupees. But then, if you have, that's the direct cost, but then there is an additional of 6,500 rupees of indirect cost, because if there is, the patient job days are lost, and the bystander job days are lost too. And that is where it becomes more costlier. So, but then, if you introduce a good low molecular weight heparin, which is 1,914, and if you could give it as a prescribed dose and a standardized therapy, the benefit of avoiding a pulmonary embolism for a patient is close to 49,000 of rupees. So a VTE prophylaxis of 1,000 or close to 2,000 of rupees versus 49 or 50,000 of rupees, we need to make that choice. One, we need to follow good medicine practice. We need to follow evidence. We need to also give, do no harm and give that benefit. So every action which we do is extremely beneficial to the patient and it's cost effective. So if you look at quality adjusted life years, number of persons utility value is 0.82. The pulmonary embolism person's utility value is 0.63. The PE, pulmonary embolism per QALY is 12.6. And QALY gained, if you are following good practice of DVT or VTE, is 3.84. And that is very, very good. So if you look at, sorry, can we go back? So if you look at if the prophylaxis is given to this patient with a pulmonary embolism of 3, and where generally a QALY of PE patient is 1, we are saving a total gain in quality adjusted life years of 2, which is a very, very big gain. Just following good practices. There is no additional cost, just following a standardized treatment guideline practice, and a gain is close to 50,000 rupees. Let's come to healthcare-associated infection, because infection prevention is largely being practiced. And one of the chapters which we are very, very proud of, because the gains which we see in infection prevention practices are plenty. HIC 5 basically talks about surveillance, a good surveillance system of all device-related associated infections and surgical site-associated infections. But can we cost it? Yes, it could be costed. And we need not always copy and paste. We need not always say everything in a dollar term, because it may not be, excuse me, can you see? Or everything in a dollar term, because in US, surgical site infection rate is close to $90,000. And for them, that is the costliest healthcare associated infection, which is not. In India, for us, ventilator associated pneumonia is costliest, which is close to 61,000 of rupees. And urinary tract infection is the lowest, which is close to 20,000 of rupees. So every infection is a cost. And these, the aggregators of all the insurance companies are also coming together. And someday, the IHI has already introduced, Center for Medicare and Medicaid has already introduced. They're not going to pay for any of these healthcare or hospital-acquired infection. And even in India, these are questionable. So how do we cost it? So there are some direct costs, there are some indirect costs. What is important is also to get the indirect cost into it. Plus, there is an additional stay cost and an opportunity cost if you do it well. So if you just do good hand hygiene in one department, before intervention, 1434 CABG done, post hand hygiene and the whole department participation, CABG done 1404, but the surgical site infection avoided is 40, and cost saved is 21 lakh of rupees. So every bit of good practice, evidence-based practice, or your standard treatment practice is cost-effective and cost-benefit, and that is what we need to look at. So comprehensively, this is just one department costing for healthcare associated is close to 84 lakh of rupees. When we look at it in global term, the gains in one department in 1 year is close to 2 crore of rupees. So my investment in training, which is 770 per training session, $1 of investment, the return of investment is $230. So why should not I invest in accreditation and put my money into good quality care delivery practice and evidence-based. There is also cost of bad will and litigation, which is immense, more so in a state like this, which is very, very litigant. Now, let's look at another example, which is antibiotic stewardship. So we followed a model called as Donabedian model, which is a structure, process, and outcome. So whatever you see in blue is a structure month on month. We follow a process which is in green, and then we keep measuring that process in red. So that's an outcome. But it is done by a multidisciplinary team meeting every time, because there are ID physicians, there are clinical pharmacists, and then there are other group of people who are also present. So we measure these good practices, we measure the length of stays which are gained, and good antibiotic stewardship practice is also close to 2.35 crore in throughout the hospitals, and that's a good opportunity. If you looked at antibiotic prophylaxis, one group of surgical team which was not doing, and another just because they were avoiding surgical site infection, and the other who practiced surgical site in good practice of antibiotic stewardship, the surgical site infection actually dropped. So this is a very, very vague and weird idea that pumping more antibiotics drops the surgical site infection. So these are some early warning signs. Implementation, you reduce the state to or conversion to cardiopulmonary resuscitation and shifting. That's again, if your revenue per operating bed in critical care is 50 to 70,000 rupees, you have dropped it by 77%. So huge gain. But then it only happens if your team is good, your response is good, and you follow good practice. My last bit is about application of technology for evidence. So there is this idea that you need to invest in new technology, and that is extremely valuable. So earlier there was in radiation oncology a cobalt therapy machine, then there was linear accelerator, and then the cyber knife came in, which has a robotic arm. And we believe that with each introduction of technology, there is a good science which has been practiced, and it is value add. But we need to do that costing well. So this is a cost-effective analysis for cyber knife. Look at the radiation, local control for cyber knife is 70%, but each dose of cyber knife is 36,000 rupees. Look at what happens with linear accelerator, 10 crore investment, the local control is 90%. We believe addition of technology gives you a better result, which is not, and every dose is 11,000 rupees. So just investing on higher technology may not make good evidence, and that is where rationality and appropriateness of practice is what accreditation drives, and that would be important. So I'd like to end with this. Accreditation does bring in, and I think we all, and you are all, your being here proves that you are all committed towards accreditation. But what is important is that we need to learn to put in a good cost-benefit, cost-effective analysis and make this as a good business process. Thank you very much for your attention.